Dear all, we will see today a new complete case of ESD of an adenoma which was developed completely around and into a diverticula in the right colon, and we used a strategy with multipolar adaptive traction attract. So it's one of the training in practice area of the ESD school with a new complete case of a kind of challenge, because it's not an easy case. It's a difficult strategy into the diverticula, and you will see that the strategy is really relatively similar to the strategy we use for appendiceal ESD, because we will have to do a circumferential incision, a very strong traction to tighten and to pull the diverticula outside his hole, and it will be an ESD which will turn around the diverticula all around in order to have the traction mostly on the diverticula itself, removing all the submucosa around the deepest part of the diverticula, and once the traction will go down, we can, if needed, tighten the device, increase again the traction, and remove the lesion, and at the end the diverticula will come back, will appear again, because the traction will go down. So this is the case. Unfortunately, the bowel preparation was not perfect, so the image is not very clear at the beginning. You can see this lesion, which is somehow 15 millimeter, but really centered by a deep diverticula in the right colon in a patient with a lot of diverticulas, and one is really at the center of the lesion. We couldn't see any invasive pattern into the lesion, which was mostly irregular, and we could begin the resection. So we did, and it's very important, a very strong injection with pressure at the oral edge of the lesion. It's very important to do this incision with a strong injection, with a high pressure injection, because thanks to this high pressure, you will be able to do both the incision and the trimming in an opposite way. I mean, it will be possible by doing a down position of your row. You will be able to do both incision and trimming on the good edge. It seems difficult to do because you are not tangential, you are obliged to do down, but in fact it will be possible to do the incision because the injection is very strong, and immediately the trimming, which is down on the edge, but on the good edge. I mean, it's not an opposite trimming to the oral side of the incision. It's a good trimming in the anal side of your incision, and it's very important. Really, you should spend time doing this trimming, because at the end it will help you a lot to fix the traction on this edge, and also to turn around the diverticula once the traction will be on the lesion. So it's very important to spend time doing this injection and this incision on this edge. Once it is performed, we will totalize, complete the circumferential incision. Here it was not so easy because we were close a second diverticula, so it was quite challenging to have large margin on the right side of the lesion. So we had to do it very slowly, trying to go on this area, which has a very shallow submucosa compared to to the conventional one we can have in the colon. And finally, I prefer to let it for the end, doing the wool access on the left side and later on the anal edge of the lesion. And immediately after each incision, I try to have a good trimming in order to open the space and prepare my late ESD all around the lesion. Once again, in this strategy, we want to turn around the diverticula in order to let the diverticula for the end, getting the more pressure from the traction, the more traction on the last fibers into the diverticula, and not spending this traction to the normal submucosa around the diverticula. So it's very important to prepare the end of the resection by doing this circumferential incision and trying also to do a circumferential dissection also in order to have a strong traction at the middle of the diverticula for the end of the resection. So we enlarge our incision and trimming from the injected area. I don't use so much the needle after the initial injection. I try always to come back from the edge, which is already injected at the good depth, and coming back from it and enlarging progressively my circumferential incision. So all the incision are followed immediately by a trimming in order to get a good access to submucosa immediately after the injection, because if you lose time for it, you will have a lot of leakage of liquid, because when you do your incision, you create a lot of leakage, and therefore the fluid injected in the submucosal cushion will go. But if you do your trimming immediately after the incision, the liquid is still trapped, is still blocked into the submucosa, and then it's easier to do your trimming and to access to the submucosal layer relatively quickly. If you prefer to do a complete incision and come back for trimming, usually it's a little more difficult, because when you come back, your cushion has decreased a lot because of the lot of leakage created by your incision all around the lesion. So in this area, I like to have more margin, I should say, because it's easier for fixing the traction and for having large margin to reduce the vascular density, because under the lesion you have more vessels, so it's more difficult. So I like to have more margin, but in this case I wanted to find a compromise between margins and trying to avoid to remove a second diverticula on the right where there was no lesion. It was only a diverticula on the edge, and you will see it will take time, because we have to go very slowly to go into the valley and obtain a cutting of the mucosa without damaging the muscle. So I have to pull back my knife, but you can see that we are very close to the diverticula entrance, and we have to go relatively slowly to open the space. So a small bleeding is coming. It's usual. Commonly you can have this kind of bleeding on the sides of the diverticula more than at the bottom of it. And once again, I should cut, but very slowly, with a movement of pulling back the knife. If you push it, you have a risk of damage of the muscle, because usually the submucosa is very thin into the diverticula. So here, if you go quickly and strongly and deeply with your knife, the risk of damaging the muscle is not probably low. So once again, I pull. I use the dual knife like probably we could use the hook knife by pulling back my needle and trying with the ball of the electrode to have this kind of hooking effect in order to pull back the mucosa and have a cutting without deep contact on the muscle. Finally, we could have this complete section, even if it's not perfect and not very good. But at the end, thanks to traction, it will be easier to achieve the resection. And a small trick probably is that when you have a bleeding like this, you should go on and do your incision a little largely in order to make the bleeding point visible. Because the most difficult hemostasis you have is when you don't know where it comes from. So if the space is not open and it bleeds into your incision but without seeing where it comes from, please enlarge, please cut, even if there is blood, because you will save time by opening the space and seeing where it comes from. So here, it's a little blind incision, but it's sometimes needed to open the space and be able to go under to access to the submucosa. So I inject, and I try also to inject by opening the space, and after I try to do a blind movement, but always moving on the opposite side of the muscle. I like to have a quite large flap in order to fix the traction without any risk of trapping muscle while catching the edge with the clip. So here it's a little difficult to go under. The area is quite small, the space is not very large. But by doing the trimming, using underwater strategy when needed to make the edge floating, it's a little easier to open the space. And as soon as we will see that the space is large enough, we will change for a pediatric transnasal forceps, rat-tooth forceps, but transnasal one, in order to insert the attract device, the multipolar adaptive traction device, into the channel in order to fix the traction. And you will see it will a little change the game, because it was not so easy to go under the lesion from now, but once the device will come, it will be easier. It was quite difficult to insert the device. Usually it goes smoothly, but probably there was some residue into the channel because the bowel prep was not very good. The patient did it well, but probably because of the hundreds and hundreds of diverticulas everywhere, we had a lot of residues trapped into the diverticulas. But finally, thanks to something to make it sliding into the channel, it was possible to introduce the traction device. So yes, the lesion is not so big, but using EMR in this case will not go to a complete resection, because it's impossible to have the bottom of the diverticula with a snare, because the bottom of the diverticula is deeper than the bowel wall. So for me it seems impossible to have a complete resection using a snare in this case. So here you have the residue coming and preventing a little the good way of the resection. We use mostly Boston clips because for this purpose it's better to have a clip that is rotatable by the physician. It's a little easier to control the rotation by yourself than having a perfect coordination with the nurse, but if you have a very good coordination with your nurse, it is possible to use other clips, but I like to turn by myself because it's sometimes challenging to catch the loop. So here it was really in the stool, so not easy to catch. So one trick is to pull back the device and make it outside the stool and the residue. So after we catch the fixed point, the goal is to fix it on the oral edge of the lesion without catching, if possible, the muscle. So you should have a kind of pulling movement while closing the clip in order to catch the edge but without catching the muscle. Here it appears a little difficult, so I prefer to do it again, to put water in order to have the edge and the edge of the lesion also, but I also have the edge, and it will make the traction relatively strongly on the oral edge of the lesion. So the second active loop is the blue one. So yes, again, residues, but you will see as soon as the traction will change the gravity of the lesion, we will stop the problem of residue coming into the field of view. So we use a second similar clip, once again to be able to turn it by ourselves. We try to see the second blue loop, which is the active one. In this case, it was difficult to see, so I moved the device in order to see the second small loop, which is here, just in front of us. It's always a little challenging, and we are working on it to reduce the difficulty to catch this loop, which is not so easy. So here I like to do a kind of fold with the clip because it's less damaging in case of tension. If you grasp only the edge, you can tear the specimen and cut it. If you do a fold like this with two sides of the mucosa doing a fold, in case of clip ablation, usually you have no damage on the specimen, it just rip, it slide, and you don't prevent your ER0 resection. So I like to catch the fold like this and not catching only the edge tangentially. But I will explain it in a future episode about how to fix the traction on the lesion. And after, I want a very strong traction, if possible far from the bad gravity side. So I deflate the colon a lot and try to fix it on a fold at 90 degrees on the opposite side. I deflate again in order to catch a lot of tissue and avoid the clip sliding or removing. And after, thanks to inflation, you are tangential to the submucosal layer and to the area you want to cut. So usually it makes the resection really easier, and in this case it's also changed the gravity because all the stool and residue are going into the deepest part. Here you should go slow at the beginning of this part because sometimes the muscle is also attracted by the traction, like here. So the initial incision and ESD is relatively difficult, but it was really difficult before traction to find this area. Here you can see really good exposure. We see really where are the submucosal fibers, but we should go slowly to identify the muscle layer and be sure we will not damage it while cutting the submucosa. We probably have a lot of fibrosis around this diverticula, so it's usual to have a space which is relatively narrow compared to conventional colonic ESD. And we will find the layer, and you will see, thanks to traction, the area will open, and it will be even more easy with time. I mean, once the initial dissection is down, the space is increasing and the stability of the scope will become better also, and finally it will be easier to cut and to see the good exposure. So here you can see there is a small vessel. We have some area which are blind, you're right, but thanks to good movement, trying to go outside, to pull back and to avoid pushing, we will finally see the layer. Yeah, it needs a training to recognize the muscle layer tracted by the traction, you're right, but nevertheless, for me, it's better to see exactly where we are and where is the submucosa, even if the muscle is going and is tracted, than doing only blind movement, which are somehow dangerous if you do all the procedure without seeing very well. So after this, we will try to turn around the diverticula. So the diverticula is at the middle, and we will try to cut the submucosal fiber, re-injecting and re-injecting again, to cut only the blue area, and you will see progressively we will enter into the diverticular space. It's difficult to go very fast in this case because you don't dissect tangentially in only one plane. You have a lot of 3D change. I mean, first we are going up and then we will go down into the diverticulum. We have the edge to cut where there is another diverticula which is fixing the submucosa. So yes, it takes time. Patience is needed for this kind of case because it's quite difficult to cut in only one way and to go fast in the same direction. You should spend time to remove all the fixation and all the submucosal fibers all around the diverticula in order to open the space. So what is needed now is to turn around, I said it before, because it will concentrate the traction only on the deepest part in the diverticula. If you don't remove the submucosa which is on the oral side of the diverticula, your traction is not only on the diverticular area, it's also in the normal submucosa at the oral edge of the diverticula, and if you have more fibers to tract, your traction force is less important than if you let only the diverticular area where you have all your traction force concentrated in the deepest area of the diverticula. So turning around is very important. Removing all the fixation, the adherence of the diverticula around the central part will make your success later in the procedure, and it's sometimes, thanks to traction, possible to turn around and have a kind of lateral approach like this, cutting the submucosal fibers from the lateral side, and removing the tension in the oral edge of the diverticula. So once again we can inject, we can cut the submucosal fibers, and you can see that we have the entrance of the diverticula here with a submucosa all around the diverticular mucosa. So here we turn around, we try to find where are the last fibers. It's not very quick, I'm sorry, but it's exactly the same for appendiceal cases, exactly the same strategy. I mean, injecting this small space between the muscular or the bottom of the diverticula or the bottom of the appendix and the mucosa we want to remove with adenoma. And we can find a layer, even if it's small. It's feasible to remove this layer. And you will see at the end there is something at the bottom of the diverticula. It's not really a perforation. You have a tissue which is not muscle or only the longitudinal one, but there is a space. It's not totally open. So here we see that the area which is tracting a lot, that prevents really the good traction on the diverticula at the bottom is here, and therefore we should spend time to open this area. It's a little difficult because the space is very narrow, but nevertheless it's feasible, and once we will cut it, it will really open the space easily, and the end of the resection will happen quite quickly now, but we still have to open this area on the edge of the diverticula with a second diverticula in the right part of the lesion. So here you can see we take fiber by fiber very slowly. Okay. We see that it's here that the force of traction, the adherence is the most important. And once we open the side, it will really open the space thanks to traction quite easily. And it will make the end really easier than it is now. So here. In this case, because the walls seem a little fragile after this, we prefer to close everything in order to prevent a delayed perforation or a delayed diverticulitis. So we closed all the area. Here we can see okay, small bleeding on the side. We can see that there are a lot of vessels around the diverticula. We use a combination. Traction is really needed for this kind of case, but underwater can also help. And combining the different strategies is sometimes really useful. It depends really of the gravity, the easiness of the case, but in difficult case like here, it's nice to have all the helps we can have with both traction, underwater, cap assistance to improve the visibility, RDI if needed in case of more important bleeding to see, because in this case, if there is a bleeding, it is sometimes dangerous to coagulate because you can damage the mucosa or the muscle. So you can see that it's coming, slowly but coming. And progressively, the force of traction is only on the center, and therefore it opens the diverticula and it turns the diverticula itself, so it makes the exposure easier thanks to this traction. And once again, we should turn around to remove all the fixation points that are remaining all around the diverticula, because if you still have some points, it prevents the traction to get all the diverticula outside his hole. So once again, I try to turn around. I'm very cautious here because I don't want to damage the mucosa. And you will see that we will reach the bottom of the diverticula, because during the injection here, you will see, it will increase the space, showing that there is a communication between here and the opposite side of the submucosa. We could see that it changed the shape of the diverticula to inject. So we know that we are at the bottom now. This picture was important because we saw that injecting from the anal edge could open also the oral edge, showing that the bottom is almost reached, and it will be easier to achieve the resection here and cut the last fibers to remove the lesion completely. It's a little dangerous here because the muscle is in front of us, so we should have lateral movement and not going frontally with a direct view. It's better to turn around, to still turn around. Small bleeding here. I remove the water to see. The RDI button was not where I was looking for it, because depending on the room, we have not the same setting everywhere. So I was looking for it in the number 1 position of my scope for my therapeutic, but here it was number 2. The setting was not perfect in the room I was. So, but I like to use this mode because sometimes the window to find the bleeding is not very long and not very large, and it's sometimes you only have 1 second to see where the bleeding comes from, and thanks to RDI, sometimes you see where the bleeding point here is. Also with conventional light, sometimes you don't see it, so it will not change completely the things and make the bleeding point really visible if it's in the blood lake, but sometimes the window to see it is a little longer thanks to RDI, making possible to clearly see where it comes from. So the water was a little blurred by the blood, and therefore the resection is almost achieved. Only small fibers that came mechanically, and you will see that the bottom is not perforated. There is a layer it's not free, we are not in the peritoneum, and we could close it completely thanks to small incision all around, because it makes, I like to do this incision to have a better grasping of the edge without clip sliding on the edge of my resection. So here a small bleeding during this kind of incision. So I needed to coagulate this area. Okay, one on the opposite side, and usually one clip is almost enough to close the diverticula, and after I use 2 or 3, I don't know, to complete the closure and be sure that there is no delayed damage of the muscle. So the water is not very clean, so I tried to do to remove the dark water and to change it for clean one in order to see better. Once again, you see the bottom of the diverticula, which is not free of nothing. There is a tissue at the bottom. And the clip is coming now. I use my 2 incision to close it. Okay. So the area is closed, and we added, I think, 2 or 3 clips around this one to be sure of the complete closure. I don't perform a lot of incision in this case, because once one is fixed, it seems relatively easy to close the 2 edges thanks to this first clip that close the area and make it relatively safe for the diverticular part. Second clip is coming. It's relatively long because we use reloadable clip in order to reduce the waste. So it takes a little time to reload and fix it compared to single-use one, because single-use clips are 90 degrees or 90 grams of waste. The reloadable one is only 5 grams for the second one. Instead of using a new handle for each case, we have only one handle and reloadable clips from Creo Medical, which are reloadable, rotatable, reopenable. So it combines the advantages of single-use clip, but with a reloadable type of clips. So we like the Boston one when we need something precise to turn by ourselves, and the Creo one because it is reloadable and it reduces the waste and also the cost. Thanks to this reloadable device, the only disadvantage is the time, because reloading is not so easy. So this is the specimen with the diverticula at the bottom. And finally, to summarize, colon ESD is feasible in diverticulas. We use the same strategy than appendiceal ESD. You should spend time for the oral edge. It's one of the key of the success. Precise strategy should be followed. Oral injection, under pressure, deep incision and trimming, circumferential total incision, and traction. I think it is quite impossible to do it without traction, at least for me. And sometimes tightening is needed to increase traction during the procedure. There is something in the deep part of the diverticulars. It's not a complete perforation, but nevertheless, closer seems better to stay safe and avoid delayed damage of the wall. Thank you very much, and to finish this small reminder of the strategy: circumferential incision, multipolar adaptive traction, strong traction, circular dissection all around the diverticula to remove the submucosa that reduce the tension and the traction at the middle of the diverticula. And finally, when the force of traction is concentrated into the center of the diverticula, it is easier to be tangential to the deepest part and complete the ESD resection to have this R0 resection of a high-grade dysplasia adenoma without positive margin, and therefore this patient is cured and will have his next colonoscopy in 3 years. Thank you very much and see you soon. Best.